My name's Annette McWilliams. I'm a respiratory physician who works in Perth, Western Australia, and I'm one of the international lung screening trial investigators. And I presented, and I was I submitted a late-breaking abstract to the World Lung Cancer Conference in 2025 on behalf of the team, and it was luckily accepted for the Presidential Symposium. I got an opportunity to present the work in the symposium yesterday. Okay, so the work that we've been doing in the International Lung Screening Trial was conducted over multiple different countries including Canada, Australia, multiple sites in Australia, Spain and Hong Kong. And there was two main aims for the International Lung Screening Trial. It's really been running now for a number of years, and we're just completing the 5 years of follow-up for all the participants. And then there's two main aims of the study. One was to prospectively validate enrolment of participants using the PLCO-M 2012 score to assess if they're at risk and compare that to the USP-SDF criteria. And we actually presented that work a few years ago now. The second main aim of the study is really the topic for this presentation, and that was to validate prospectively the use of the PanCan Nodule risk calculator to manage nodules that we find. We know that we find nodules very commonly on screening CT. And really the best management program varies. There's lots of different protocols around the world, and we're using a risk-based approach. And we developed this PanCan risk model some years ago, and it was published in the New England Journal in 2013, and it's been retrospectively validated. So in the International Lung Screening Trial, we wanted to prospectively validate it and to see how it performed against the LungRADS criteria. So that's what we were able to present this work. So we had over 4,000 participants with nearly 5 years of follow-up now, and we were able to show that using the PanCan Nodule risk score, and that protocol based on using that PanCan risk score, was really effective in triaging people just on their entry CT scan, on one CT scan only, with a very simple tool and risk calculation. So it was very useful. So what we've shown using this, the PanCan nodule management protocol, is that it's highly effective at triaging people at screening entry into a low-risk category or a high-risk category, and actually performs better than the LungRADS categories. And it enables about 75% of screening participants to be safely rescreened in 2 years rather than 1 year, and thereby reducing the number of CT scans that the participants may need to have, subsequently reduce resource utilisation and cost. So that's really important. And secondly, it was better at triaging people to a high-risk category. We found that using PanCan nodule management protocol, only 2.8% of participants were triaged to a high-risk category, but half of them ended up with lung cancer, and that was statistically highly significant compared to the LungRADS protocol, which, if you use the LungRADS protocol, 7.4% of people were triaged to the high-risk category, but only 18% of them ended up with lung cancer. So using the PanCan protocol really effectively showed it was able to more streamline patients at screening entry to low risk or high risk, and making it a lot more simple, enabling 75% of people to just have a repeat CT scan in 2 years' time rather than 1 year. And that can be cost effective for a program. So the use of the PanCan nodule management protocol is now already been implemented in British Columbia by my colleague Stephen Lamb, and it's incorporated into the screening program for that province in Canada. And it has also been proposed, it's going to be used in Australia's program, which is starting next year in July 2025. We'll also be using this PanCan nodule risk score at baseline for screening entry for our participants, and it will enable us to have a biennial program rather than annual program. And that's really useful for a country, I think, for our participants and for countries with public health systems and, trying to be more cost effective, because it means that we're not sure yet, but it may help people adhere to the program, and we'll have to see how that goes. We haven't proven that yet. But if it enables patients to only have a scan every 2 years, that may be more acceptable to them. It will certainly reduce costs and reduce the thousands of CT scans that might need to be performed. So it's a big cost saving to a program, and certainly a program that will be federally funded like Australia. we know that the largest cost to a screening program is the CT scan cost. So if we can reduce the number of CT scans that a participant requires safely, then that's a big cost saving to the health system and to the program, and also less interventions for the patient. This is really important for a country like Australia because we'll be having mobile screening for our very remote and regional areas, and that the big mobile trucks will be coming through those regional areas will only be going through every 2 years. So it'll be more effective and easier to manage a 2-year program, especially trying to get people into to a scanner every year in very remote areas is quite problematic. So that could be quite an effective strategy for us in Australia for our regional and remote areas.